Good evening, everyone. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the brand new season of Optometry Series 3.0. In this particular season, we're dealing with instrumentation parts of optometric and ophthalmic instruments. I'm very happy to welcome a team member. Nancy has joined here. Thank you so much, Nancy, for joining with us. And Nancy ma'am will be about to join in another 5-10 minutes. And we're very happy to welcome the moderator for the day, Archana ma'am. Archana ma'am, thank you so much for joining, ma'am. We're so
Thank
glad that you're here for moderating the session, ma'am.
I'm also equally happy. Thank you so much for inviting.
Thank you, ma'am. To know more about Archana ma'am, I'd like to call Niranjan, the student and third year student, to share more details about Archana ma'am.
Good evening, everyone. I am Niranjan, studying third year Bachelor's in Optometry Multimedia team member at Dr. Agarwal's Institute of Optometry. I am very happy to welcome the moderator of the day, Ms. Archana ma'am. Ma'am is a senior optometrist with extensive clinical and academic experience in field of eye care. Archana ma'am worked at Sankarnethalaya, Chennai from 2005 to 2014, gaining a valuable experience in clinical optometry and patient care, especially with glaucoma department. Ma'am also served as a visiting lecturer at Lotus College in Coimbatore between 2018 to 2020, contributing to the academic development and training of the optometry students. Ma'am has moderated lectures at PPG College of Optometry and been an examiner at Avinash Lingam Institute of Optometry, Coimbatore. Archana ma'am professional journey includes a strong blend of clinical expertise, teaching experience, and a passion for optometry education. We truly delighted to have you with us, ma'am, today as a moderator.
Thank you, Mr. Niranjan. That was a very nice introduction.
Thank you, ma'am. The presenter of today is Ms. Shivani, third year Bachelor in Optometry student and General Secretary of Sports Club at Dr. Agarwal's Institute of Optometry. Shivani, please start your presentation.
Am I audible, ma'am?
You're audible.
So, good evening, everyone. I'm Shivani, studying BSc third year at Dr. Agarwal's Institute of Optometry. So, today our topic is about gonioscopy. So, let's start with it. So, gonioscopy usually is a clinical technique used to examine the anterior chamber angle of eye using a special lens called gonio lens. So, it allows a clear and stable visualization of angle structures that cannot be seen directly through a slit lamp. It is essential for detecting glaucoma and planning appropriate managements. Next, the principle of gonioscopy. It is based on the eliminating total internal reflection by placing a gonio lens on the cornea with a coupling fluid. Coupling fluid is nothing but a transparent fluid placed between cornea and gonio lens that eliminates the air interface that causes a total internal reflection, and it allows a clear structure visualizations of angles. Next, optics of gonioscopy. Gonioscopy is based on the principle of direct illumination and direct observation. So the principle are when a light from a slit lamp is directed onto the anterior chamber, when placing a gonio lens, which is an indirect illumination, the light enters the eye, striking the anterior chamber angle structures and is getting back reflected. The reflected image is viewed through a gonio lens, which is an indirect observation. So looking at this image, when a light is directed onto the eye, the light rays pass onto the eye through cornea and reaches the anterior chamber, and in that the angles are getting visible from the eye to the gonio lens, which is Zeiss 4 mirror lens kept at an angle 59 degree. Next, classification of gonioscopy. They are broadly classified into direct gonioscopy and indirect gonioscopy. Gonioscopy, where the lens is placed directly on the cornea to view the anterior chamber angle. Whereas in indirect gonioscopy, we use a condensing lens view the anterior chamber angles indirectly that gives a virtual, erect, and magnified image. So for direct gonioscopy, there are a few types. First is Scopy lens, which has 50 diopters concave lens in two sizes, mainly used for infants and adults. Second is Hoskin-Barkens lens. It is a type of surgical gonioscopy available in various sizes and have blunted edges. Third is Swan-Jacobs lens, used for surgical purposes, especially allowing access for goniotomy. Fourth is Richardson Schafer's gonio lens. It is basically a type of copy lens mainly used for infants. Fifth is Worth gonio lens. It anchors to the cornea by creating a partial vacuum on the eye. Next, sixth is Short's gonio lens. It is a small type of gonio lens used for infants and children. And seventh is Thorn lens. It is used for both surgical and diagnostic lens. Eighth and last is the Leyden lens, diagnostic lens for evaluating the angles. And next is indirect gonioscopy. There are four types of indirect gonioscopy. First is Goldman gonio lens, Zeiss gonio lens, third is Posner, and fourth is Sussman gonio lens. So these are the images of direct gonio lens. This is a Copy lens and Hoskin Barkins, and this is Richard Schafer's gonio lens, Swan Jacob lens. So the technique includes the patient is placed in the supine position, then the anesthesia is instilled with 4% of xylocaine. Then the gonio lens is placed directly on the cornea and a coupling fluid is placed between gonio lens and cornea to eliminate the total internal reflection. Then the angles are directed and viewed visibly. Then the examination of anterior chamber angle in all quadrants will be examined. The advantages are greater flexibility where the observer's positions can be changed and panoramic view, one part can be compared with other. Easy to see the angle where the patient's positions can be changed if required. Useful in children to observe more deep of anterior chamber and less distortions of anterior chamber. Can be done in both sedated or anesthetized patients. Provide a straight view rather than an inverted view. Both eyes can be examined with both two lenses and useful during surgical procedures, especially for goniotomy. And disadvantages are comparison is not possible. Limited positions of light rays. It is more difficult to perform in horizontal meridian and excessive pressure may open or close the angles artifactually. Next is indirect gonioscopy. It is also a type of method by examining the anterior chamber angle with a gonio lens containing a mirror or prism. So it redirects the light rays from the angles to the observer, allowing more and visible visualizations of structures that cannot be seen directly with a slit lamp. Next is types of indirect gonioscopy. The first type is Goldman gonio lens. Goldman gonio lens is a type of multi-mirror indirect gonio lens that uses mirrors to redirect the light rays from the anterior chamber angle to the observer, making more visible of angle structures. There are three types of Goldman mirrors. They are one mirror type, which is a large one mirror kept at 62-degree, usually used to look at drainage angle, and it's great for laser treatment such as trabeculoplasty. And for two mirror type, it has opposite two mirrors placed at 59-degree and 73-degree, usually good for laser treatments. And three mirror type has full design built in three mirrors with different angles of 57-degree used to view the drainage angle, 67-degree to view the mid periphery, and 73-degree used to view the outer edges of retina, which is the ora serrata. These are the three mirrors. This is the one mirror which has a large mirror and two mirror placed in opposite directions, and third mirror is a fully built model. And next, second type is Zeiss 4-mirror gonio lens. Zeiss gonio lens is a 4-mirror indirect gonio lens that allows the examinations to view the anterior chamber in all four quadrants without even rotating the lens. So for Posner four-mirror gonioscopy, it is also a type of four-mirror indirect gonioscopy with a handle that, that helps to visualize the anterior chamber angle and facilitate a dynamic gonioscopy, which is an intentation gonioscopy. Next, the last type is Sussman four-mirror gonio lens, which is also a four-mirror. It is an handheld indirect gonioscope used for examination of anterior chamber angle, particularly for intentation gonioscopy. Next is the technique. Here, the patient is placed in the slit lamp and anesthetized, and then the indirect lens is placed on the cornea with a coupling fluid. Then the angles will be directly viewed and the angles will be examined in all four quadrants. The advantages are wide field of view of the anterior chamber angle, allowing examination of entire angle, suitable for slit lamp examination, provides a magnified and clear view of angle. They can be used different type of gonio lens for different clinical purposes. Next is disadvantages. It requires a contact lens on the cornea, may cause corneal irritations, requires proper positioning and alignment of lens. Image may be distorted depending on the lens type and requires skill and experience for proper interpretation. Next is indications. To assess whether the anterior chamber angle is occludable or open. So to detect abnormalities of anterior chamber angle, diagnosing and classification of glaucoma, especially for angle closure or open angle glaucoma. Detection of abnormal angle structures such as peripheral anterior synecdoche, abnormal pigmentation, neovascularization, and angle recession. Evaluating after ocular trauma, particularly suspected angle recession, and before laser procedures or evaluation of unexplained raised intraocular pressure. Next, the contraindications are the gonioscopy should be avoided in the following conditions where the patient is having corneal ulcer or active keratitis, corneal aberrations, or severe corneal edema or compromised cornea, acute conjunctival or corneal inflammation, ocular trauma, which has been recently occurring when associated with hyphema, suspected or known perforating injury of the globe, recent intraocular or corneal surgery, recurrent corneal erosions. And if severe corneal surfaces diseases, severe ocular pain or inflammation. So next, there are three type of gonioscopy technique. The first type is gonioscopy in situ. Second is manipulative gonioscopy. And third is intentation gonioscopy. So first, what is gonioscopy in situ? It is a clinical technique that is used to examine the anterior chamber without moving its position, keeping in its natural position without changing the angle. So the technique used in gonioscopy in situ is two-mirror gonioscopy lens that is used to obtain a maximum in situ view. So for this, the patient is asked to look straight ahead with the lens on the eye. The room lights should be dimmed. The slit illumination and height are reduced so that the light does not fall on pupil to avoid pupillary constrictions and avoid artificial opening of angle. The angle is then observed in situ to assess its occludability. So if the angle is not visible, the closure may be an optical or apparent closure due to steep iris configuration or appositional closure or synechial closure. Next type is manipulative gonioscopy. Definition: for manipulative gonioscopy, the observer move or manipulate the gonio lens to make more obtained angle structures to be visible. So especially when a steep iris configuration is present, the examiner moves or manipulate the gonio lens to make the angles more visible. So for technique, in routine gonioscopy, the angles may not be visible in some cases when with an steep iris configurations. So by doing this manipulating gonioscopy, the angles may be more visible and clear when the eye have over, steep iris configuration, which is an over the hill view. So with this method can also be used with the Goldman type lenses and by asking the patients to look in the direction of mirrors, moving the mirrors towards the angle being examined. This helps visualize the angle and identify whether it is a peripheral anterior synecdoche. Next, the third type is indentation gonioscopy. Indentation gonioscopy is performed by applying a gentle pressure with an gentle pressure on the lens that pushes the aqueous towards the angle. If the angle closes, if the angle opens with the pressure, it is indicating as oppositional closure. If the angle does not open with pressure, it is considered as synechial closure. So the structures seen in gonioscopy from anterior to posterior are Schwalb's line, trabecular meshwork, scleral spur, and ciliary body band. So these are the four structures that is seen in the gonioscopy. The interpretation of gonioscopy. The angle is assessed by identifying the structures visible in the angle. The structures are viewed from anterior to posteriors are Schwalb's line, trabecular meshwork, scleral spur, and ciliary body. If the angles are wide open, all the angles may be visible. If the angles are narrow, posterior angle structures are difficult to visualize. For closed angle, the angles will not be visible due to contact between peripheral iris and trabecular meshwork. For peripheral anterior synecdoche, which is the adhesion of iris and the angle structures. For grading, the main grading is used by Schaffers to estimate the angle width and assess the risk of angle closure glaucoma. So these are the types of grading. The first type is sheath grading, where wide open all structures may be visible. For grade 1 narrow, the iris root to recess difficulty to see, which is the ciliary band is difficult to see. Grade 2 narrow is ciliary body band obscure, where the ciliary body band will be hidden. For grade 3 narrow, posterior trabeculum obscured, and grade 4 closed. Only the Schwalb's line will be visible and no other lines will be visible. And next, for Schaffers grading of anterior chamber angle, the fourth grade with an angle width of 35 to 45 degree with a configuration of wide open, the risk of closure will be absent. For grade 3, the angle width with 20 to 35%, the configuration of open angle will, the risk of closure will be absent. And for grade 2, with 20 degree, moderately narrow, and the risk of closure will be possible. For grade 1, angle width for 10 degree and very narrow, the risk of closure is very high. And for grade 0, angle width with 0 degree, configuration closed and the risk of closure will also be closed. So RP center gonioscopy grading. So grade 0 is no dipping of beam and grade 1 is dipping of beam. Grade 2 is Schwalb's line plus anterior one-third trabecular meshwork will be visible. And grade 3 is middle one-third trabecular meshwork will be visible. And for grade 4, posterior one-third trabecular meshwork will be visible. For grade 5, scleral spur. And grade 6 is ciliary body band will be visible. So grade 3 or less than grade 3 is considered as narrow. For grade 2 or less than grade 2 is considered as closed. And the clinical uses are assessment of anterior chamber angle, detection of narrow or closed angle, diagnosis and classifying whether it is a glaucoma or what type of glaucoma, detection of peripheral anterior synecdoche, assessment of angle recession after trauma, detecting abnormal angle vessels, and evaluating before laser procedures. The limitations are it requires a contact gonioscopy lens, it requires patient cooperation, examination is operator dependent, excessive pressure on the lens may alter the angle appearance, corneal opacities may reduce visualization and requires proper slit lamp illumination and magnification. Thank you. These are my references.
Thank you, Shivani, for the detailed presentation on gonioscopy. So, ma'am, I would like you to add any points if you have anything on your mind which would be helpful for all the viewers.
First of all, it was a good presentation, Ms. Shivani. Thank you for the presentation. I think she is almost the points. Only thing she had multiple points on the slide. Otherwise, it was a good presentation and she had covered everything what gonioscopy a person should know when it comes to gonioscopy. So coming to the gonioscopy, the types of gonioscopy, direct and indirect, we don't follow direct gonioscopy except for the surgeons. Only during the surgical procedures, they use gonioscopy only if it is required that too. We always follow indirect gonioscopy in our routine clinic. Okay. And there are indirect gonioscopy, the lenses which you told, the Goldman 1 mirror, 2 mirror, 3 mirror, all these lenses, they require a coupling solution. But there is a gonioscopy, indirect gonioscopy that can be done without the coupling solution, only anesthesia, topical anesthesia. That you use Zeiss, Posner, Sussman, it is Sussman. Okay, so the Zeiss 4 mirror, the Posner 4 mirror, and the Sussman 4 mirror are done, are gonioscopy, which is being done without the coupling liquid. Okay, the direct gonio lenses, the 1 mirror, 2 mirror, 3 mirror, which you told me is done with the coupling liquid. So there are two differences. So in routine gonioscopy, people prefer without the coupling solution because once you use the coupling solution on a patient during a routine checkup or examination further by the consultant, by the doctor would be really difficult. It could be blurred, the fundus could be blurred, and the slit lamp exam, the patient will have blurred vision. Okay, any photography, suppose the patient is going for any fundus photography or any other procedures, that will give you a blurred image because of the coupling solution. So most probably we prefer not to use it. Okay, except in uncooperative patients, patients who are unstable in the clinic, children whom we cannot perform gonioscopy, we prefer doing a direct gonioscopy in the supine position. That will be done on the table during the operation theater. That is where they use the direct gonio lenses. It gives a direct view of one single view. Okay. There are lenses which are used during the surgery itself to when they are doing trabeculoplasty, and then those are the surgical lenses which you told me. Can you open your slide? Can you go back to your slide? Go to the direct gonioscopy, please. Yeah. The Leiden, the Thorn lenses, and the Worth gonio lenses. And this is called the Keppe lens. Okay, the Keppe lens is mostly used during the surgical procedures. Okay, this Goldman gonio lens is only the direct, it is an indirect gonio lens, but it is used with coupling solution. The other three works without the coupling solution. That's what I told you. Okay, just go to the next slide. Next slide. So usually the indirect gonio lenses, the Goldman gonio prism, no, the 1 mirror, 2 mirror, they don't have an handle. Although being an indirect gonio lens, they don't have an handle. But the Zeiss, Posner, and Sussman, they do have a handle. So it becomes much more easier for the clinician to use it on the patient. Okay, and you don't dim entire room lights, you don't dim, you dim only 50%. 50% you leave it illuminated, because if it is fully dim, what will happen to the pupil? It will,
Constrict.
yes. So it will dilate, right? Dilate. So if it is dilated, all the more you will go for a closure. Okay, if it is a closed angle, it can be an acute closure or anything. Yes. So
Yes.
always you have a partially dim room light, not the complete dim room light. Okay. And as you said in your slide, you should not direct the light entirely on the pupil. It should be away from the, it should be on the iridocorneal, the limbus. You keep it on the limbus and only you shine the illumination. Okay, you don't place it on the pupil, because placing it on the pupil, you can see a false recording of the gonioscopy. So you for the right eye examination, you use the right lens, and left eye examination, use the left lens. You have to be very comfortable using the right and the left hand. So you use the left. You can't use the right hand for the left lens. Okay. And this is all for the direct gonioscopy. When we use in the clinic, we use only the indirect gonioscopy, that is more comfortable for the patient and for the clinician. Okay. So you read out the advantages already. You explained it so well. So, and the angle in direct gonioscopy is much more easier to see, because it gives you a complete view, and it is not a inverted image. It is a direct image. Okay, so real image. So you need not see it as lower angle as upper angle. It is not an inverted one. But in indirect gonioscopy, it is an inverted image. So if you're seeing the upper angle, you're seeing the lower angle. Upper image is a lower angle. Lower image is the upper angle. So when you keep rotating, you have to remember what you're seeing, and you have to record it in the file. Okay. So, and just go to the next thing. Disadvantages. Yeah, okay. Usually direct and indirect gonioscopy both analyze the angles the same, okay, except for that this is little more cumbersome than direct gonioscopy. The indirect gonioscopy is not that cumbersome, and it can be used in the in-house clinic. Okay, so next slide. Yes, so indirect gonioscopy, the only thing, the lenses and everything is different, and the method, every time you cannot make the patients in a supine position, except for children and unstable cases. Everybody will not be comfortable sitting and using everything. So that adds more advantage in the indirect gonioscopy. In the clinic, you will be able to ascertain whether the angles are open or closed. If it is closed, then what would be the further procedures? What the clinician, the consultant decides can be decided. Next slide. This I already told you. Okay. Okay, this handle will help you to use the gonioscopy more comfortably. Okay, instead of holding it in hand, you can you can rest your hand down on the slit lamp table and use it with the handle more comfortably rather than holding the gonio lens in the hand by yourself. And you always have a good rest on the slit lamp table so that you are stable. Your hands doesn't shake or anything, because you are resting it on the patient's cornea. So you should be very careful, and by mistake also you should not indent on the cornea. There is a difference between manipulative and indentation, as you described. See, manipulative works only when the iris is very steep. It is called over the hill. Okay, there's a large difference between manipulative and indentation. You are just manipulating, just changing the position to see if the angles are opened in a manipulative gonioscopy. But in indentation gonioscopy, in the normal room light, you don't see at all. Okay, indentation is one beyond the manipulative gonioscopy. In manipulative gonioscopy, just by tilting, you don't indent on the cornea. Indent on the cornea, you're giving the pressure on the cornea so that the angles are opening. You're seeing whether the angles are opening up with the pressure. But in manipulative, you're just only tilting the gonio lens. You're not doing indenting on the cornea. Okay, so manipulating, like if the iris is very steep, you will not be it is called the over the hill iris actually. When it is over the hill, your angle structures will also be not seen. Okay, so always they write it as over the hill, steep iris in those cases. But indentation, you give up when you see the angles are not visible at all. You give a little pressure on the cornea to see whether it is a cynical closure or a closure because of only the angles are closed. Okay, so if it is a cynical closure, the angles will not open. Wherever the cynicae are, the angles might not open. But in other places, it might open up. Okay, because it is a normal closed angle, which is only just a angle closure. There is no rise in IOP, but everything else is normal. Only when angles are closed, then you just give a slight indentation and the angles might open up to ciliary body or sometimes up to ciliary band also. Okay, I have a picture of, will I be able to share a picture here? 1 minute. I don't think so. I'll be shared. Okay, you can, the image you included was good. Okay, that is a depiction actually. If you see it as human eye, you will know how clearly the pictures are actually. Okay, you will see usually the Schwalbe's line. It's called the Schwalbe's line. Okay, what is a Schwalbe's line? You said it is a Schwalbe's line. What is a Schwalbe's line? You know what is a Schwalbe's line? What do you say as anatomically? What is a Schwalbe's line? So it's a peripheral termination of the Descemet's membrane. Okay, the Descemet's membrane, it perfectly terminates into the Descemet's membrane, that is called the Schwalbe's line. It is an opaque structure in gonioscopy, which is normally not visible on gonioscopy except there is blood in the on the Schwalbe's line. Okay, and if there is pigmentation, like in posterior embryo toxon, there will be a lot of pigmentation in the Schwalbe's line, then it will be visible. Similarly, Schlem's canal. Schlem's canal will also be not visible. Only when there is a blood in Schlem's canal, it will be visible. Okay, so beyond the Schwalbe's line is the anterior trabecular meshwork. Anterior trabecular meshwork, as it is said, it is not pigmented. The PTM, you can remember as ATM, anterior trabecular meshwork, and the posterior trabecular meshwork. The posterior trabecular meshwork is the pigmented one. The anterior one is a non-pigmented one. Okay, so it will be more pigmented. The pigment in cases of corneal endothelial pigmentation and endothelial dystrophies, you can see the pigmentation being much more in those cases in the posterior trabecular meshwork. Okay, so mostly in pigment dispersion syndrome, you have heard about pigment dispersion syndrome in your ocular diseases. Okay, you may learn in your future. So in pigment dispersion syndrome, you will have pigment dispersed on the endothelium. So that will be seen in the trabecular meshwork. So you more than a normal one, you can see a very densely pigmented one. So you will have to, when you note down when they note down the gonioscopy, they will write how the pigments are very densely pigmented, very lightly pigmented, and everything. Mostly you will see till the scleral spur. If the scleral spur, it is seen, it is a normal open angle. If it is beyond the scleral spur, you see a blackish band. It is called the ciliary body band. Okay, so if you see, it's a very wide open angle. Mostly in myopes who have a very deep anterior chamber depth, you will do a gonioscopy and you can see till the ciliary body band. Only thing, you will have to be very careful. When you do it, you don't initially itself, you should not indent on the cornea. You will have to just place it on the cornea. Make sure you are not giving pressure on the cornea. Okay. Next slide. Can you go to the slide which you showed me the angle structures? You have a picture of the angle structures, right? It was in the beginning. Yeah, it's a good slide, but you have a very good actual pictures in the web. When you see, you have taken from Kurana. You can also refer Kansky's. There are many online journals which give more references on gonioscopy, very recent also. Okay. So this is the Schwalbe's line. This I told you is opaque and you will not see it. And then comes the trabecular meshwork. You can see the trabecular meshwork, this one, okay? So it is pigmented. It is separated into two things, anterior and posterior. The posterior only will look pigmented, okay? You have better pictures of in the web. I think the ciliary body band is the you can see how blackish it is. It will be brown to blackish, a band-like structure, okay? And sometimes you will see even iris processes from the ciliary band. If it is a very deep angle, no, you will see all those also. Okay. So next slide. So wide open angle. So indication of gonioscopy. When and all you feel gonioscopy is intended. Have you is gonioscopy being done in the routine? Have you been seeing people doing gonioscopy, optometrists or the doctors, consultants doing? Have you observed in the clinics?
No, ma'am.
No. Okay. You've seen any videos of it being done? Okay. So when do you do gonioscopy? When there's a basic glaucoma history in the family itself. The family history is very important in glaucoma. Somebody having a blood relative having glaucoma, it is a very important history and it carries a gene. Okay, a strong family history, if it's noted, then you will have to do a gonioscopy, even if the angles are open, IOP is normal, irrespective of all the checks, you will have to do gonioscopy. Okay, even if the anterior chamber is deep and the intraocular pressures are high or on the border, you will have to do. Okay, any previous history of any blunt trauma. Okay, the angle recession which you said, it happens because of the mostly of the blunt trauma, any ball injury or shuttlecock injury. Mostly because of that, you can have angle recession. Angle recession can be present in one quadrant, in two or three or four. Okay, all four quadrants. Angle recession can lead to angle recession glaucoma. Okay, patient can have a wide ciliary wide anterior chamber depth. And you can see that you will miss out the IOPs might also be normal, but post dilation, it can rise up. So you will have to, once the eye is dilated, you will not be able to see an angle recession. So only under undilated conditions, you can assess a proper angle recession. Okay, so even narrow angle, sometimes you can miss an anterior trabecular meshwork, you can miss with indentation. So you will have to be very careful. If you dilate an eye, then eye can go to an acute attack of angle closure. So if you are not that in your beginning stage, if you're not that confident, get always clarified, because it can go for an acute angle attack and the patient can have a very high shot of IOP and you will have to bring it down and all this. Okay. So most probably you mentioned 3 types of gradings here, but commonly what we use and what has been following is a Schaffer grading, which it goes without any confusion, and mostly it is works for many of us. Okay, the Schaffer grading. Next slide. Next slide. You can skip the gradings and finish with the gradings. Okay, so it is, and mostly for anterior chamber angle and angle closure, we use gonioscopy to find out any angle recession, any unexplained IOP increase. Then you will have to see if you have missed an undilated gonioscopy, then you will have to see an gonioscopy in undilated state. You will have to call the patient, come back. Usually they take a post-dilated IOP also if required. Family history, you will have to do everything irrespective if the patient even is normal, has no symptoms. Okay, even if the discs are normal, it has to be done. Okay, next. If there is blood in the anterior chamber, blood in the AC and anything, again you will have to see what is the reason for the hyphema and anything. Okay.
Okay.
You have any rubeosis in the rubeosis iridis because of diabetic retinopathy or any other reason, there can be any neovascularization of the disc, CRVO and all can have rubeosis iridis. So that time you will have CRVO can lead to secondary open angle glaucoma. So those cases also you will have to do a routine gonioscopy, not only because of the angles. When this rubeosis iridis, blood in the anterior chamber and all this, can be blood in anterior chamber, can be because of trauma and can be because of many other reason too. Okay, but the rubeosis iridis can also have many multiple reasons like diabetic retinopathy and CRPO in like in ischemic CRPO and all. And it is an early onset you might not have, but a prolonged onset you can have. Okay, so you'll have to do, if even you find a new vessel in the iris like rubeosis, you'll have to do a gonioscopy. Should not. Okay, and yes, it is requires patient cooperation, and it is operator dependent. You will have to be very careful in handling gonioscopy. You will have to have a very good base. Okay, you have to rest your arm, whichever arm you're using the gonioscope, you will have to rest it very flat and use it very stable. Okay, either you can place a box or you can place something as a base to keep it straight so that your hand doesn't tremble. Okay. Yes, contraindications of gonioscopy. Yes, the previous slide. So any corneal ulcer, see corneal ulcer, active ulcer you don't do. Otherwise, if the ulcer is obscured the cornea, there is no need to do gonioscopy at all. Okay, any fresh epithelial defects, you will have to be very clear. You don't do all these conditions. Yes, cornea or any epithelial or endothelial conditions you don't do, because endothelial cornea, you have any rupture or anything, you indent and it will go for a bigger issues. Okay, so there is a corneal rupture and it can go for bigger ruptures also. Okay, a small, because you are indenting on the cornea only, right? So it can go to a bigger rupture. So okay, the rupture can become bigger in size. Okay, and any acute you see redness, unless you rule out conjunctivitis or keratitis, you don't do gonioscopy even it is a shallow AC. Okay, anterior chamber grading, I hope you know how to you've undergone slit lamp class, right? You will know how to grade your anterior chamber depth. Yes. So depending only on the anterior chamber depth, you will have to do your gonioscopy. So recent ocular trauma and yes, suspected lacerating injuries, any corneal conditions, you defer gonioscopy. Okay, especially conjunctivitis and all. And there is something when there are patients like HIV patients. In those cases also, if gonioscopy is indicated, either if somebody is asking you, a clinician is asking you to do, a consultant is asking you to do, then you will have to follow normal. How do you disinfect normally all the instruments and everything? You will have to follow a normal disinfection for those. This is also, you will have to disinfect for some time, and you should not use the gonioscopy because you will be transferring the infection to another patient. Even the tears carry 1% of the virus. Okay, suppressant virus, it carries 1%. The tears carry 1%. So you should be very careful. Okay, in HIV patients. So next slide. Next slide. Okay. This is gonioscopy in situ is mostly done with the direct gonio lenses. Okay. So you use the coupling solution. Normally you do direct gonioscopy. You use the coupling solution. It is like you make the patient supine position. You place you anesthetize the cornea. You place the coupling solution between the eye and the gonioscope, and you place it, and you just view the complete angle. Okay, you will not, in these cases, you will not be writing as upper, lower, nasal and temporal. You will be writing as a complete angle open or it's closed. Okay. Next slide. Okay. So coming to the closure, like Oppositional closure and cynical closure. I told you what is oppositional closure. When the angles open on indentation, so that is an oppositional closure. Cynical closures, whatever indent you indent on the cornea or pressure, give pressure on the cornea, the angles might not open up at all. Okay. Next slide. Next slide. Next slide. Next. 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 Keep going until I stop you. Okay. So you try taking references. There are multiple online references. Okay. Except for Purana, you refer Kansky and see? Yes. No, you didn't refer Kansky. Okay, try referring Kansky also. Multiple, you have many online journals which also give good information on the thing. You can be little more elaborate. You were elaborate, I don't deny it, but little more elaborate so that you carry a little extra information except what you have on the slide. You always, when you explain, you read out the points, that is all good, but you need to have some extra points more than that on the slide so that it your audiences will get some inputs from your session. Okay. Any doubts?
Oh, thank
Thank you so
Any other
much, ma'am. I think you've covered everything very detailedly. Like all the questions that I had in mind has also been answered. So thank you so much for this wonderful session. I would like to give it over to Ms. Komati now for the final conclusion.
Yes, thank you so much, Nancy. Archana ma'am, thank you so much for moderating today, ma'am. So thank you for sharing all your insights, ma'am. It is a very detailed explanation from your side, ma'am. We're so glad that we had you today. And I would like to ask Anshika, ma'am. So Anshika, ma'am, thank you so much for pulling in Archana, ma'am, today.
Thank you, Anshika, for this.
Hi.
Hi.
Thank you so much for joining today. I'm so sorry I joined very late, so I could not get in, but the last inputs that you gave were excellent. And thank you for finding time and teaching us so much.
I'm so glad after a long time
Yes, yes. We've also learned everything from you only. We used to attend with her and we used to be very scared when we used to be with her. But thank you, Archana. Thank you so much for joining today. Yes, Gomati, over to you.
Yes. Thank you so much, Archana, ma'am. We'd like to host you on another wonderful platform, ma'am.
Thank you. Bye. Bye. See you, Anshi.
See you. We'll get in touch with you again soon.
Yeah, sure. Definitely. Bye.
There's a small announcement, ma'am. I'll make the announcement, ma'am. Yes. So thank you all for your continued support towards Optometry series. There is an exciting workshop that is coming next month. So I'd like to call Nancy. Nancy, please share more insights about the workshop as being one of the in charge. So what we should look forward in the workshop.
Okay, so hi all viewers. So this workshop is going to be on vision therapy. This is going to be a complete one-day workshop with a lot of hands-on and basic to the advanced of vision therapy and binocular vision is going to get covered. And there is also exciting activities and prizes that is being planned for this event. And along with this, we'll also give a small kit to all the participants along with your certificates. So looking forward to all of you being a participant of this workshop. This will be held on 20th of September, a Sunday, which is easy for all of us to come and attend. And this will be a workshop for the whole day from morning 8 o'clock to evening 5 o'clock. So hoping to see you all, and the registration link will be announced soon on our page. So stay tuned for that. Thank you.
Yes, thank you so much, Nancy. I just make sure that the link for the registration will be available in our description box. So thank you, team. Thank you, Nancy. Thank you, Anshika ma'am, for joining. We like to have wonderful sessions much more in the future. So thank you all for your continued support. We'll meet in the next episode. Thank you. Bye.